Hello, my name is Constantine Raptis, and I'm from the Malignant Institute of Radiology. I'd like to welcome everyone to the resident session at the STR 2021. I wish we were doing this in Las Vegas. It certainly would be a lot more fun, but we're stuck with virtual this year. And I'm going to be the first speaker, and my topic is the anterior mediastinum. So let's start by just defining the anatomy of the anterior mediastinum, which is also known as the prevascular space. And I think the best resource for defining the anatomy is the International Thymic Malignancy Interest Group, which has published a bunch of papers about the mediastinum, including this one, which defines the boundaries of the mediastinal compartments. The anterior mediastinum extends superiorly from the superior aspect of the thoracic inlet, which is basically the upper margin of the manubrium, inferiorly to the level of the diaphragm. It's bounded by the parietal pleura on the lateral aspects. Posteriorly, it's bounded by the pericardium and the great vessels, and anteriorly by the sternum. I think multiplanar reconstructions show the space nicely. It's this space right here. What lives there? Well, the thymus, which involutes to fat in most adults, fat, lymph nodes, and the left brachiocephalic vein. It's a fairly straightforward space in terms of normal structures. But it gets a ton of attention in teaching, both with medical students and with residents, and the teaching really revolves around the T's, right? Everybody knows the T's of the anterior mediastinum. The first one shown here, it's a young patient, a relatively encapsulated mass containing fat, fluid, soft tissue, and some calcium or bone. This is just a mature teratoma, so very easy diagnosis here in this young patient. We've got this mass up here. It's an older patient. It's relatively well encapsulated, intermediate level of enhancement, kind of lobular. Call it a thymoma. It's going to be most likely most of the time, and that's what this is, the second T. And the third T is shown here, a huge mass that kind of is encasing vessels and going into the middle mediastinum, associated with some effusions. This is going to be a terrible lymphoma, the third T. The fourth T is one I actually don't like. This one shown here, it's a lesion in the mediastinum that we could connect up to the thyroid, so it's a goiter. Some goiters, like the one on the right, don't actually connect to the thyroid, and you just have to be able to identify what a thyroid outside of the thyroid looks like. But I don't like thyroid goiter in the anterior mediastinum because almost all of them are middle or posterior mediastinal, just like these two. These are both posterior to the brachiocephalic vein. They're not anterior mediastinal masses. They're middle mediastinal masses. So typically I don't think of them in the anterior mediastinum, although we do occasionally see them there. The compartments of the anterior mediastinum as defined by ITMIG really don't allow for a whole lot of thyroid goiters. But how's it going in real life? Well, in real life, you see anterior mediastinal masses, and you certainly see the classic ones, but then you'll run into ones you're just not going to get up front. This was a plasmacytoma. That wasn't first on our differential. This was a young patient who had this cystic mass with soft tissue in the anterior mediastinum. We thought for sure was going to be a germ cell tumor of some type or a teratoma. Turned to be histoplasmosis granuloma. Sometimes you'll be really sure you know what it is because it's a patient who's presenting with a mass growing around the vessels, and that's typical of something like lymphomas associated with effusion. It's very classic, and you'll say that and biopsy it and find out it's a seminoma and just get fooled. And on occasion, you'll need to recognize something outside of the box that has different treatment. This is a patient who had previous coronary artery bypass grafting, rounded lesion in the anterior mediastinum containing contrast and some thrombus. This is a coronary graft pseudoaneurysm. So how do I think about the mediastinum? I kind of go beyond the T's and really focus on management, and that's how I want you to think about the mediastinum as well. And when it comes to management, the choices are simple. You can do nothing, get more imaging, follow something, biopsy it, go straight to surgery, or do some other treatment. Now, some of the presenters say we'll have questions built in. The questions for each of my cases is the same. What is the next best step in management? The question is going to be at the top of the screen. After I show the case, the answer will light up, so you can kind of play along as the cases are shown to you today. All right, let's start. We got a case here. This is a young patient, 30-year-old. We take a look at this radiograph, and the first thing that stands out is an abnormality along the left aspect of the mediastinum. Our normal moguls, or border of the left border of the mediastinum, is going to have our aorta, our pulmonary artery, and where our left atrial appendage would be. Okay, this patient has a concave left atrial appendage. There's this extra bump here, okay? And we know that that's not pulmonary artery because we can see the pulmonary artery bump through it, and we can actually see the hilar structures through it. Okay, so that's a bit of the hilar overlay sign, meaning it's either got to be anterior or posterior. And I could buy, there's a little bit of vague soft tissue or increased attenuation anteriorly, but this mass does one other thing. It displaces this line medially, and you only see the right border of it. And that line is what's known as the anterior junction line. It's where the lungs come together anteriorly. You can see that on a CT. This is a normal patient, normal anterior junction line. This patient displaced anterior junction line. So we know we're dealing with an anterior mediastinal mass. More imaging in this case was needed. This showed a well-encapsulated mass containing fat, fluid, and soft tissue in the anterior mediastinum. Patient this age, this is a mature teratoma. Very high level of confidence. Basically, if you've got a young person, you've got some combo of 2 or 3 for sure, fluid, calcium/bone, soft tissue, and fat in a lesion in the anterior mediastinum, you're going to be very confident that you're dealing with a mature teratoma. This can go straight to surgery, and that's what it was. Now, not all teratomas have that full mix, right? This is a patient who came in, was a young woman actually, predominantly fluid-filled lesion in the anterior mediastinum, very little soft tissue. We thought this was going to be some sort of unusual duplication cyst or pericardial or thymic cyst, surgically resected, mature teratoma. Okay, so you don't have to have all the elements to have a mature teratoma. Now, not all germ cell tumors are teratomas. This is a patient who has a big lobular mass in the anterior mediastinum. It's mostly soft tissue, small amount of fluid, kind of described as intermediate level of enhancement. This is a decent look for a seminoma, okay? And that's what it turned out to be. It turned out to be a seminoma on biopsy. So just another type of germ cell tumor. Germ cell tumors, more common in younger people. That's something to remember. But this happened to be in older patients. So they can happen at any age. They're just rarer over the age of 40 to 50. Occasionally, germ cell tumors can present in a more aggressive form. This is kind of a twofer case. This 26-year-old with Klinefelter syndrome has a very nice chest radiograph showing this lobular mass projecting over the left hilum. So we get the hilar overlay sign. We actually get a little bit of that displacement of the anterior junction line again. So consistent with anterior mediastinal mass. If you know that Klinefelter syndrome is associated with germ cell tumors, you pretty much know what that is. But this case is something else, this bunch of Mets, okay, a bunch of pulmonary nodules. So this is a malignant germ cell tumor of the anterior mediastinum, and we got more imaging here, and this turned out to be a sort of necrotic mass with very irregular soft tissue on its borders. Didn't have any of those more differentiated materials like calcium or bone or fat, just soft tissue and fluid in this case. We saw the Mets. This turned out to be sort of a mixed non-seminomatous germ cell tumor on biopsy. Ended up treating the patient with chemotherapy because of the presence of the Mets. The nodules improved. The anterior mediastinal mass lost all its soft tissue. Patient ultimately went to surgery. This was resected, and no further tumor was found within it. So we treated with chemotherapy first by making the diagnosis of the Mets, and then we get the surgery and a very good outcome in this case. All right, take this patient, different demographic. This is an older patient, 7 years old with dyspnea, and you saw the last case. This one is even more subtle, but you've got a little bit of an increased density here, right? And we're displacing that anterior junction line again. So you might wonder, am I dealing with a small anterior mediastinal mass? Perhaps something up in this area. And when you look at the CT that we ordered, we can see that there is indeed a finding there. And the lesion is pretty well encapsulated. It's got soft tissue and fluid in a 70-year-old, sort of incidentally discovered. The patient just had dyspnea, is probably not related to this. This turned out to be a thymoma, and that's what we called it ahead of time. This type of lesion can go directly to surgery. No aggressive features, incidentally discovered. Soft tissue or soft tissue with fluid, particularly an older patient. Pretty high confident diagnosis in this case. Clues of thymoma include clinical factors, such as many of the patients have paraneoplastic syndromes, the most common being myasthenia gravis, but we can see other neurologic related things like Lambert-Eaton. You may have patients with hypogamma or pure red cell aplasia. Another pearl, so to speak, with thymomas is, while they often have that lobular or well-circumscribed anterior mediastinal soft tissue mass that may have fluid in it, they do have a proclivity for invasion, both of mediastinal structures and the pleura. So anytime I see a mass in the anterior mediastinum, and I'm concerned it's a thymoma, take a very, very close look at the pleura, and that combo of an anterior mediastinal mass and the, quote, lumpy, bumpy pleura should really point you to a thymoma. When you see invasive thymoma, other treatment, such as biopsy and or chemotherapy, may be pursued prior to surgery. All right, third type of lesion shown here. Patient, a pretty large patient who has what looks like a wide mediastinum. I mean, that's the best way to put it. And that mediastinum goes way down. And again, we can see the hilar vessels through this widening. So we're concerned that there's a mediastinal mass here. It's probably not vascular, given how inferior it goes and the fact that we can see the hilar vessels so well through it. CT shows an almost entirely soft tissue mass in the anterior mediastinum that's associated with some lymphadenopathy, up more cranially and inferiorly in the pericardial fat. This constellation of findings, that big mass plus the nodes, should at least raise some suspicion for lymphoma. And when lymphoma is on the differential diagnosis, a biopsy is a good idea because you don't want to surgerize lymphoma unnecessarily. Oftentimes, prior to the biopsy, we may get a PET CT or an MR to look for the hottest area or the area with the most diffusion restriction to target our biopsy to that location. That's what we did in this case, and this turned out to be a lymphoma of the anterior mediastinum, which is treated with chemotherapy. Think lymphoma when you've got clinical clues, something like fever, night sweats, or weight loss, so-called B symptoms, to trigger an idea that you may be dealing with a lymphoma. If you've got a big mass in the anterior mediastinum that's all or mostly solid, that's a pretty good look for lymphoma. And those masses, which can be other things too, typically do deserve biopsies. If you've got a mass that encircles vessels but doesn't occlude them, great look for lymphoma. If you've got a mass that's associated with a bunch of lymph nodes, okay, lymphoma is a disease of lymph nodes, that should trigger a potential diagnosis of lymphoma, and you might want to go after the most easily accessible nodes, which could be supraclavicular, avoiding a dedicated mediastinal biopsy. And finally, if you've got a big mass plus pleural or pericardial effusions, okay, that's something that we often see in lymphoma too. So when we see that combo, think about lymphoma. The bottom line here is, if you're thinking lymphoma, the next step should be biopsy, because if it is lymphoma, you can avoid the patient having an unnecessary surgery. Now, those are some of the common lesions, but you're going to run into all sorts of other stuff. And when you see something that's unusual, particularly if it's big, or particularly if it has a high soft tissue to fluid ratio, I think a biopsy is usually warranted. I mean, this could be anything, but it's a huge mass. And a huge mass has got a lot of soft tissue, some areas of potential necrosis. You got to be worried about sarcoma. This was a dedifferentiated liposarcoma. Note, no fat, because it's dedifferentiated. This was a huge mass in the anterior mediastinum, more soft tissue than fluid. It was some controversy ahead of time whether this was a lung cancer, but it turned out we biopsied it, and it was a thymic carcinoma, squamous cell carcinoma of the thymus. If you see a mass that's got locally invasive features, okay, consider lung cancers or other aggressive lesions. This patient had occlusion of multiple veins with big collaterals, anterior mediastinal mass, which was biopsied and found to be a small cell lung cancer. So good to get that diagnosis up front because the chemotherapy and radiation is going to be the choice. Sometimes you can end up with weird things. This is a lobular breast cancer in the anterior mediastinum. It's just very unusual. Lots of soft tissue. Didn't know what it was. It turned out to be lobular breast cancer presenting in the anterior mediastinal fat prior to any breast lesion. Sometimes you'll have a patient who has a known history. This patient had a known history of breast cancer, bilateral mastectomies, anterior mediastinal mass with that history. MET's got to be high on the differential diagnosis. So again, a biopsy is warranted. Bottom line is big masses with lots of soft tissue more than fluid, aggressive features or concerning histories, get a biopsy first because they may fall outside the common things that you see in the anterior mediastinum. But the anterior mediastinum is more than just tumors. And a lot of the things we do on imaging actually are to try to prove that something isn't a tumor. And you should be comfortable with what a normal or hyperplastic thymus looks like, particularly on CT. And I often say it can look like the pancreas, so it can have some sort of soft tissue and stippled macroscopic fat when there's that residual thymic tissue. It may connect to the thymic vein, okay, which drains into the brachiocephalic vein, which is a structure that I use to identify thymic tissue. The amount of fat within a thymus can vary based on the patient's age, whether they've had a recent stressor. You can see this is some normal thymus, but it's got less fat than, say, this person on the left. Occasionally, you'll get a patient who's got some rebound thymus or residual thymus that doesn't have much fat, but is small and sort of spade or triangular shape with concave borders. That usually doesn't worry me. I see this type of shape in the anterior mediastinum, and I'm automatically thinking it's probably just some benign thymic tissue. These are all do-nothing lesions. But there are times when I don't know, and sometimes it's relevant, right? 27-year-old myasthenia gravis, it's important to know if they have a thymoma. It affects surgical approach and treatment approach to the patient. This is a rounded lesion in the anterior mediastinum. I can't tell for sure if that's thymic tissue or a thymoma. We've got a choice here, though, and that choice is more imaging. And we do that within an opposed phase imaging on MR. Just like with adrenal adenomas, in an opposed phase imaging in the chest can pick up intravoxel lipid, which is a trademark of thymic hyperplasia or benign thymic tissue. When you do that, you're going to measure the in and opposed phase and see if there's dropout, plug it into a simple formula, the signal intensity index, which is basically the percentage dropout that you see. And if it doesn't drop out much, i.e. less than 9%, that's going to be typically a concerning lesion, one that's probably going to be a thymoma or other malignancy and need surgery. If you've got something in the 9 to 20% range, this lesion was about 14%, you're probably going to need to follow it, okay? Follow it in the short term to see if it stabilizes or goes away, because that's kind of an indeterminate range. And if you've got one that like obviously drops out qualitatively or is over 20%, that's very, very good for something being some benign hyperplastic tissue. Those I usually do nothing. This one, it was 14%. I followed it. We ended up getting a repeat CT and it involuted over time, consistent with benign thymic tissue. All right, compare that to this case. Older patient in their 70s, here for evaluation of pulmonary nodules, well encapsulated, instantly discovered, rounded anterior mediastinal mass. This is going to be overwhelmingly a small thymoma. Okay, they're often incidentally picked up in older patients. We did the MR, no dropout in an opposed, small amount of fluid as well as soft tissue associated with the lesion. High chance of this being a thymus given the clinical scenario and the imaging features. Went directly to surgery and a cystic thymoma was confirmed. You don't want to over-rely on the in and opposed phase imaging on MR because there are some things that don't demonstrate it but are benign. One is shown here. This is a patient with a rounded anterior mediastinal lesion measured 44 Hounsfield units. We went to MR. We thought it might be a small thymoma. No dropout, okay, no dropout from in and opposed phase. But note it's almost entirely fluid. Okay, this is our ADC map and some inversion recovery imaging, and it doesn't enhance. Okay, so small fluid-filled lesion now in the anterior mediastinum, we wouldn't expect dropout, but the lack of enhancement suggests a benign etiology, and the diagnosis is going to be one of a thymic cyst. Okay, another do-nothing lesion in the anterior mediastinum, and a chance to make a difference in the management of patients. Now, there are some other benign lesions in the anterior mediastinum that you do need to be aware of, particularly for the boards. One is the Morgagni hernia. You see a combination of fat, bowel, and potentially fluid. This patient has ascites with vessels in the anterior mediastinum. Make sure it's not coming from the foramen of Morgagni, which can be shown to advantage of multiplanar reconstructions. Sometimes patients can present with weird things. You just need to know about them in terms of clinical history. Patient with acute chest pain, encapsulated fat in the anterior mediastinum. This is sort of the correlate for epiploic appendigitis in the abdomen, a pericardial fat infarct, which can be managed conservatively with follow-up imaging. This patient was anticoagulated and high attenuating lesion in the anterior mediastinum that had no enhancement. We thought it was going to be a benign spontaneous hematoma, which ended up resolving over time. And then there are lesions where you need to know the clinical history and kind of have an idea of what's on the menu. These two patients look identical on radiograph. Big mass anterior mediastinum, hilar overlay sign. One has mean tsunami wires, the other doesn't. Top patient, non-contrast MR, T2 hypointense rim consistent with hemosiderin as well as a flow void. This is a huge coronary artery pseudoaneurysm. Treatment in this case is going to be endovascular or surgical. Bottom one, a non-enhancing pericardial cyst. So there's all these benign lesions you have to be able to interact with. You may not know them up front, but they go way beyond those T's and something that you just need to be able to think about. And that's really the summary here, how I think about the anterior mediastinum. You have to go beyond that basic knowledge, those basic T's, and really focus on management. Okay, and we talked about these different management schemes, do-nothing lesions, thymic hyperplasia, cysts, and some of those novel things I just showed you, okay, like that hematoma in the anterior mediastinum. Sometimes you may want to do more imaging, right? You get that indeterminate thymic hyperplasia that I showed you an example of. Some possible cystic lesions, one that might have a smooth rim of enhancement but not definite nodularity. You may want to follow that. Or something to look for a biopsy site, and I showed you examples of that as well. Some lesions may require follow-up, probable thymic hyperplasia or a probable thymic cyst. Other lesions may require a biopsy. The big one I talked about was lymphoma. When you see those findings that are concerning for lymphoma, I think a biopsy is very helpful to avoid an unnecessary surgery. Likewise with big, ugly masses, particularly those with more soft tissue than fluid, lesions with mets or invasion, or patients with a cancer history. Some patients can go straight to surgery. I think classic mature teratomas and thymomas, either associated with a paraneoplastic syndrome or incidentally discovered in older patients, really don't require much of a workup. And of course, there are those which require some other treatment, like a Morgagni hernia requires a sort of not a surgical resection, but a plication of and a repair of the defect. Coronary pseudoaneurysm is going to require some sort of interventional or surgical procedure. And then lesions with mets often go to chemotherapy. So, there's a big spectrum of things in the anterior mediastinum, and I hope that I was able to give you some idea of that spectrum and potentially change the way you think about the anterior mediastinum to focus on management rather than just simple diagnoses. Thank you, and I hope you enjoy the rest of the talks.